Good afternoon, everyone. Thank you very much for joining this lecture series, which aims to foster a spirit of innovation and entrepreneurship among our learners at SSMC. It's my great pleasure to invite Dr. José Mariz, who is a internal medicine consultant and head of emergency department at Hospital de Braga in Portugal. He is a POCUS leader, and he set up a POCUS training program in his hospital. Dr. Jose, thank you very much. Please do share your journey so we can learn from you and listen from you. Thank you.
Thank you a lot, Siddiq. This is really a great journey. I'm very honored to be with you in Abu Dhabi. This is amazing. This invitation comes from our passion to point of care ultrasound and share it in the online in professional social media like the LinkedIn. For me, that's amazing. And I never thought like 5 years ago, if I was thinking working here in my hospital, that I will be talking for such a wide audience. It will be like a science fiction. But this is my passion, point of care ultrasound. This is POCUSX, is my like an entrepreneur, my organization where I fulfill all my things I want to do on point of care ultrasound, and I have a fantastic team working with me. As you said, I'm a general internist in the classical way. I'm a consultant in internal medicine. I work in the emergency department, but also in consultation. Even I still doing like pre-hospital care, but we are getting old and it's getting difficult to go in the fast lane inside the city saving people. But I am also a assistant professor at University of Minho, where also I teach students in emergency medicine, and with a very focus in point of care ultrasound. And I am a coordinator of a curricular unit dedicated to fluid management and lung ultrasound. And then I want also to say I'm editor-in-chief of the official journal of internal medicine in the Portuguese Society of Internal Medicine. So I'm waiting for articles from you. Joking, okay? And coordinator at the ultrasound study group of the Portuguese Society of Internal Medicine. I want to tell this because I do a lot of things, okay? And the learning objectives of this session, I don't know what the first two, that they are like joined, and probably they will be too vague, but the difference between health system is so big between countries. I will try to put the things that are common to us in the world. It's a very beautiful thing in medicine, because we can do medicine in every part of the world, because the medicine is to treat and to alleviate suffering from human beings, and that's it. And we are all human beings in this earth. And then in the third point, I will discuss more detailed the internship we do here in our hospital in point of care ultrasound, which I am the coordinator. Okay, let's understand the role of imaging in the internal medicine department, but in medicine in general. And I'm this is out of the box. Okay, this is one of my greatest friends from secondary school. He's an astrophysicist. This photo was taken like 15 years ago, and is to show I'm an amateur astronomer too. And these are our telescopes, and we're taking photos of the universe, and this is to tell you my interest in imaging is very broad, and to show you that how this journey is leading us to a new world, that this photo was taken at this very moment. Okay, if you don't believe it, this is Andromeda Galaxy, and this is the kind of technology we have now, individuals, and that we can reach the far, so far as the Andromeda Galaxy, and with this detail. This is not fake images, okay? This is like edited by a camera, and then by a program that is doing stacking. But this is really the galaxy that we pointed off, okay? And as individuals, we can take this. This is amazing, and this relates to everything we do in medicine with technology and what we are able to do with the patient, we by ourselves. Okay, I love to read the science fiction. This is William Gibson, one of the gurus of science fiction, and he has this sentence that comes from the 80s. Okay, that the future is already here. It's just not evenly distributed. Even that we have this capability of taking images of the far universe or having an handheld ultrasound, it's here, it's present, but in some places it's still the future. And this is this paradox that we have to live with the technology. But at the same time, it focuses on humans, okay? Because the future is in our minds always, and the way how we see the things and how we see progress and how we see like the new things. And this is a journey that started not so far ago in a geological scale. In a human scale, it's like 500 centuries from the 16th century when the microscope was invented. This was really the great revolution, and then it started a quest to see the bodies, okay, to see inside the bodies. The X-ray machine was invented at the end of the 19th century and still is still with us, okay? We still use the X-ray, the microscope. The ultrasound came in the 50s after some experiments after the Second World War. Curiously, the first application of the 2D, the mode B in ultrasound came from an internist, okay, a military doctor in the United States, and to localize the gallstones, okay. And then in the 70s, the CT was invented, and it was really the axial. It's the axial, segmental, and axial type of image, and revolutionized still today, and is still like the big mark in imaging in every hospital. Not so much after the MRI giving another kind of resolution, but that is not so practical, and even in engineering so practical as the CT scan. So to this perspective of the image, focusing on image and it changing the journey of image in internal medicine, it's changing behaviors, because we are now, the journey is taking us to the point of care, and to the revolution that we have to do in internal medicine in specific, is to see that the image is a kind of thing that you can do it at the point of care at the level of ultrasound, and then you can manage better with the radiologist and the other specialties that are involved in imaging in a different way. Okay, you can put it more integrated in your clinical reasoning. But this change has a lot of challenge, because the data gets bigger every day, and managing patient data along the way, it's very difficult, and that it will affect decision making ability. And still, and mainly in Portugal, and probably, I don't know, that this is a problem, a wide world problem, that the data is still managed by departments and not by centered in patients. That is leads to an information silo, which is not always accessible when and where it is needed. Okay, and the other problem is we still have to access to multiple tools with different user interface that aren't always easy to access. To change the way we see, to change these behaviors, we have this challenge, okay? That the challenge that healthcare presents. The other problem is that the number of CT scans, this is data from the United States, but probably won't be very different in the developed world. The number of CT scans is like getting more and more the number of CT scans requested. This is the example of our hospital. And this graph, it's interesting. I'll try to explain to you. This is data from September to 2020, okay, just after the first wave of COVID. And you'll see that comparing in the bottom of the graphic, comparing with the number of imaging that was ordered, that was in the emergency department, we had like a big drop in 2020 and then recuperating slowly in 2021. But in the bottom, we have another graph that is the number of imaging that we order per patient, and that was always constant, okay? We, the doctors, still have a pattern, and you see that the CT scan is like almost half of the imaging that we order per patient per episode of the emergency department. Okay, it's like we are like formatted a way to see the patients with image, and that is very embedded in our practice. Yet the other problem is that many physicians have come to hate their computers. Because all these things involve technology, involve computers, and we are now in the paradox that they are helping us, but now who is practicing medicine at the bedside is overwhelmed by administrative work, spend more time attending data, trying to join all this data into entry, and then interacting with the patients. That is a very big problem. In reports all around the world, one of the first causes of burnout in doctors is the time they spent dealing with data in the computers. Okay, most of our time now, the clinical time we have to see patients, it's like overwhelmed by the time we are at computers and doing clicks and trying to join all the data. This is really the problem that we are having in this journey in imaging in general in our systems. And then this is the second point, but this is very close to the first one. Put it in perspective in history. I already talked a bit about that, but let's talk specifically in the type of imaging that is more often ordered. Okay, is the CT scan, and the CT scan is a good example. After 50 years, is still continuing and changing. Okay, this is the first imaging that was taken. An axial imaging, okay? It's a type of segmental imaging that is standardized, and it started by this standardization, and it evolved at this one, okay? Great example that we have to evolve to the digital imaging and communications in medicine, DICOM. And we think it for granted that DICOM always existed, but it was not present in the 70s, and even in the 80s it was doing the first steps, and that enables images to be displayed on various systems in different hospitals. And this is really a great challenge. It's for that now to solve health problems is not to call a doctor and call an engineer. Okay, and I want to make an homage to all the engineers that worked on that, because this is really a health care revolution, and to create this kind of universal language that we can share images from all around the world with different systems. And this is a great part of the journey that we still have to do, and this change we have to do in every part of the data, to being able to lessen the burden that we doctors have to work with all this data, and to get the data centered on the patient. Okay, and for that we have the Moore's law, historically contextualizing, that implies that computers machines that computers that are machines that run on computers, and computer power all are becoming smaller, faster, and cheaper with time. The law says that the number of transistors on a microchip doubles every 2 years, so the cost of computers is halved. And at your right, you have a mobile phone, and it's a great example of how this technology is evolving so fast that 5 years ago it will be impossible to have the same power that we have now. The future is now, like connecting in our mobile phone all the data of the patient, see the CT scan, and then connecting to a ultrasound probe. Okay, and this is really amazing. The contextualizing in history, there is a trend. I don't know if you know the Image Wisely, that is like a hub that was created like for data, for scientific information, the best scientific information that we could have based on evidence to treat patients. There is a hub for image, okay, but they are worried with the knowledge in the influence of radiation, okay, of ionizing radiation in the body. Okay, it's not still some like project to integrate all this data, but it's really an important problem. The radiation that we use in the hospitals with the CT scan at its core is like the 9 cause of cancers for the cumulated radiation in the bodies. Okay, it's really an important. Where is the limit of this technological development? The limit is the human body. Okay, we are seeing that Image Wisely. We have to center this in the patient. Can do every image in every patient. Okay, I don't know. The limit will be like something like in the Star Trek and the tricord, okay, that is like the universal machine that looks everything in the body. Sometimes I see the point of care ultrasound, sometimes how like the tricorder, okay. And now I will make this final part before we enter then in our internship, is the path of image and how I see it in internal medicine. And it's like I said in the beginning, it's a lot of things related with relational changes, okay? We have to understand this, to integrate this in our core of how we see patient. And this has 3 levels. It's the personal relationship and with the machine manipulation, but because with point of care ultrasound, now we are like the users. We have to have a relation with the machine. And then we have to relate differently with departments. I put like the radiology at the center because they are really the experts on imaging. And the point of care is not to substitute the radiologist, obviously, and even is not to complement. It's to work with them. Okay, it's a different kind of mission, but the missions have in the center the patient, okay? And another specialty that use imaging as well, like cardiology, obstetrics, and so on. And then the third stage, or the third level, is the relationship with artificial intelligence. As I said, Gibson said that the future is already here, okay? It's present. The future is in the present. The artificial intelligence, it's there. We are using, not as we think. It's not so a problem of the last 2 or 3 years. It's getting sophisticated, but we are using artificial intelligence for years, like choosing a movie in the TV. They use artificial intelligence to see how probably with an algorithm what will be the movie that you would like most to see, okay? And this personal relationship with machine manipulation in some hospitals is already very integrated. This is an example in the United States, where the ultrasound is like in the center. You look that the machine is connected to an ultrasound monitor that is in the center of the patient when they enter in the emergency room. I give you the example of the emergency room because ultrasound is very critical like to seeing a tamponade and a pneumothorax and a big hemothorax or free fluid in the abdomen, and this is critical to the outcome to the patient. And then there is a choreography that we have to understand where the ultrasound, for example, in the IFAS protocol, when it should enter, okay? And there are a lot of things that are already done, and we should now evolve the journey. We should like to evolve this in the wards, in the intermediate care units, in nephrology, when we are starting dialysis before and after and so on, okay? And it's very important. One of the most important articles in the last 10 years in ultrasound, if I have to choose 2 or 3, this will be one of the top papers that probably it went unnoticed for too many doctors, but passionate and who do research as I do in ultrasound, this is very important. The last author is my friend, very well-known Michael Blivus, and they talk about the point-of-care ultrasound stewardship, that we have to integrate this in clinical, with clinical integration, and we have to use the same reasoning as we other tests, okay? We have to choose very well the kind of image that it depends on the indication of the problem, the clinical indication, and then we have to work with the pretest probability, the spectrum of disease presentation that is to interpret correctly, and then to work with sensitivity and specificity to have a likelihood ratio at the end. This is very important because much of the research that we are doing in ultrasound is not a really correct one, because we are comparing ultrasound as treatments with hard outcomes, and ultrasound is not a treatment, okay? We can do the same research with the same methodology as we do with drugs, for example, and we have to work with jointly everyone that is doing ultrasound, and to think this in a kind of sensitivity and specificity, but because probably it will be different if it is in a setting in nephrology with the spectrum of diseases from hypovolemia to hypervolemia, or if it's in the setting of in the wards after the patient is like downstaging his treatments, or like staging heart failure, and it has like a different kind even of image, but of interpretation of that image, okay? And this is what we work in POCUSX, and in my internship is the 4 eyes, okay, of POCUS. And this is like a cycle, because one of the errors, and principally from the novice, is to go directly, for example, with to the interpretation, okay? And no, we have to first very clearly state what is the problem, the indication of the problem, the clinical indication, then to choose wisely the images that we need to correctly interpret and to correctly integrate, okay? And one of the things that point-of-care ultrasound and all this technological revolution, I'm not being paid, my disclosures, I'm not being paid from any brand of ultrasound machine of systems. I show you my journey and my visions, and what I think that is cool to reasoning, okay? And for example, this system shows you how the teams in a ward, for example, and how ultrasound can join the teams. Because when you are auscultated, when you are using the stethoscope, it's inside your head. And then you are saying to the other guy, and the other guy will understand, not because he's listening the same thing as you are, but because you are doing a script. And that script could be or could be not the script that is the script of the patient, of the problem that the patient has. And point-of-care ultrasound at the bedside permits you to put the teams like more connected. And I think this is a very, very strong message, and I want to give to you what is the journey that is leading us to where is to a better team working, to better working with data that is really, really meaningful at that moment, okay? Then the second point, this was the first point, my relationship with the machines, how to operate, how to integrate this in my clinical reasoning, working at the bedside of the patient. Then the second stage is the relationship with departments of radiology. In some places, this could be really, really very difficult. There are like turf wars, and we have the examples in the United States. And fortunately, these turf wars were like some of them very human, like you are going to my field, or no, I have to protect where I've been doing for 10 or for 20 years. It's difficult to change, okay? But we have examples, and good examples, and evidence that, for example, in the emergency department, working with development of an ultrasound program with different specialties worked very well. And in some places, we are having now the POCUS programs that involves all the specialities and all the imaging that is being done to the patient, and working very well. Other examples that this comes in the Journal of American College of Radiology, and they did a study. The study has some methodological problems, but still they show that when an ultrasound imaging is done to a patient and then interpreted by a non-radiologist and compared with the radiology, the radiologist lessen one images on average for every patient downstream the ultrasound. This is a good information because I think it passes two messages. We have to work with radiologists and to learn with them. And then I think this is an evolving thing, that if we put the artificial intelligence and we work on teams, we will like benefit the patient, and to being more rational and to be more efficient to choosing the right image to the patient. And this is will have implications on the time spent seeing the patient, and radiation, and the comfort to the patient. And who knows, I think that will be logical that in some contests it will have changes in the outcome of the hard outcome of the patient. And then it comes the relationship with artificial intelligence. As I said, the artificial intelligence is with us since like the movie selector algorithm, okay? And we have now digital medical assistant that works better than the movie selector algorithm. But another message is that artificial intelligence still not is substituting the humans. The humans at the end should call the shots, and it's what we have now. That started. It was very clear with stroke. Okay, the faster a person is diagnosed after stroke, the sooner they can be treated. And on average, 87 minutes after the image has been captured for cases being flagged as an urgent. And this implies that in 1 hour, like we have the equivalent of aging of about 3.5 years. And for example, the Mount Sinai has an artificial intelligence consortium for a considerable long time, and they show that they can scan in as little as 1.2 seconds with automated deep neural network surveillance of cranial images. And this is really a great help for neuroradiologists, neurologists, critical care doctors, okay? And as Stefan Yip, that is a guru on artificial intelligence, he is a neuropathologist, and he has a lot of research on artificial intelligence. A system that just flags people who require special attention could be really a powerful tool. It tells people that machine learning is not to replace their job, but is going to make their jobs easier, okay? This is really good stuff for thought, okay? I won't like to go too deep on that because I'm not an expert, but it's really to put this in context and what artificial intelligence it's doing in medicine now. Now, I will talk you specifically in ultrasonography, I will invite you to read the article that is ahead of print in our journal of the Portuguese Society of Internal Medicine by Michael Blivas. It is in press. I think in the 20th or 21 of May we'll have online, okay? But is already published, written and peer reviewed, and I can show you here. And Michael Blivas, it's a small review on artificial intelligence and ultrasonography. And the ultrasonography has some specific problems that are related to the kind of images that is ultrasound. And despite these nearly 3 decades of ultrasound education, we are not clinicians still competent to perform and interpret an ultrasound examination, okay? And the vast majority of these have no ultrasound skill at all. Even I'm being like involved in medical education with ultrasound for almost 15 years. Michael Blivas helping me a lot. Is like, for me, it's a mentor, a friend, and a mentor in ultrasound. And I have to agree with him. And even in my hospital, with such the effort I'm doing every day, we still don't have like the vast majority doing point of care the ultrasound. And the artificial intelligence in POCUS education could be very, very important, specifically to internal medicine, the concept of artificial intelligence guidance. And we have to change seeing the machines not like doing an automated calculation, but showing to the performer that if he is in the right place or not. And it's a thing that in ultrasound it's very important, because in the CT scan you enter and you are like laying down always in the same position, but in ultrasound you are always changing, and we have a lot of different windows. And it is by that some of the first artificial intelligence in ultrasound failed. And the famous article from the 50s, Work with New Electronic Brains, that changed the way how the programmers doing the machine learning, says that the quality image are required to train good algorithms which enable a reliable and accurate diagnosis of quality images from patients. But that doesn't work the same in ultrasound. In ultrasound, you work too many times with images that are not so good images, and we have to augment our databases on point of care ultrasound, and that is a challenge, and that is where the journey is leading us, okay? And we have to think on that. Then to end, I will show you how we integrate point of care ultrasound in clinical teaching in my hospital, that is Hospital de Braga. Is a hospital in the north of Portugal, is a central hospital with 750 beds. We have almost all the specialties, without the only exception is cardiothoracic surgery. It's a big hospital and a university hospital. And then the definitions of point of care, we stress a lot that is the 5th step of the physical examination, and we work with the evidence that we already have, that it decreases the length of hospital stay and is more appropriate and cost-effective management when using this technique. And we use it mainly like answering a simple question, preferably yes or no, and that's why is the core that I teach to my interns. We don't have too many evidence of how many images do you need to become an expert. We need research on that, but we work with what the American College of Emergency Physicians tells us for a long time, that probably is 25, 50 for each system evaluated, that it leads in internal medicine, for example, a total of 150, 300 exams throughout their training, okay? And this skill acquisition is vital, okay? And it's by these standards that we work. We are being the pioneer in the use of point of care ultrasound in our context in Portugal. Of course, there are other hospitals, but we were the first that integrated really this type of training in the internship, and mainly in internal medicine residents. We started in 2019, and we have been covering residents from the north, south, and Iceland, Azores, and Madeira. So far, we have trained 104. We're still evolving. This number should be now adapted. Probably we are now 110 or 10 or so. But then we grew, and we are steadily receiving per trimester like five residents. We have like a small brochure, like a manual, to introduce with the general objectives, specific objectives, optional objectives. We can adapt to specific things that the residents like. I want then to start to do consultation in autoimmune diseases, and I want to apply ultrasound, and then we can change some of the windows they are training to adapt to that. And the very, very important is the image portfolio, and like that we have to make sure that they reach those numbers of 25, 50 images per system, and at the end it's on average 200 patterns that recommended. Okay. And then we divide this in three stages. The kickoff POCUS is the first 4 weeks of internship, and this is the very core and the concept of the 4 I's in POCUS: the indication, image, interpretation, and integration, and all the manipulation of the machine, the knowledge, and so on. We have some residents that only come to start with this kickoff, okay, and we don't call it really an internship, but a small introduction, and then they integrate in their hospital where they are having their formation, but they could use it then to evolve afterwards that. But the most of the residents, they do 3 to 6 month duration. 6 months is very rare. We only had 2 or 3 residents that did 6 month duration, but most of them 3 months. And these 2 levels is to develop the portfolio of ultrasound, and then integrate and even with research and publications. One of the most important things are the internship sessions that we keep always online to record all the sessions, and then we can review the images that were shown, etc. And more than 55 presentations were made, focusing clinical cases in protocol revisions, but then diverse topics as like intracranial hypertension, focusing palliative care, invasive techniques, fluid management, or even VEXOS in the ward, for example. And one example I'll show you. This is an image discussion. This is like a kind of, this is a bladder view, okay? And then it has so details that this is a emphysematosis cystitis. And then we discuss all the artifacts that we are seeing, all the details of the images, and we took a lot of time doing this kind of analysis with every resident. Since January, we have registered more than 1,450 patients, still evolving. This is not like actualized. And we saw in a sample of 240 POCUS that we found that in about 20% our strategy changed, because this is integrated in the clinical question, and then the change, like not doing the CT scan, or doing appropriately the CT scan, or diagnosing a deep vein thrombosis that permitted to discharge the patient earlier, etc. Okay, we work with a competence assessment. I highlight one of the examples that we check even knowledge, if they know how to turn on and off, choosing the probe, the presets, control the freeze, and so on. And then we have competence assessment to every aspect, like heart, like abdomen, etc. Then the posters, it is very important. Some of them are before our started our internship, because our group like is going for 10 years, okay, and we started in 2019. But we had appearance and doing work with Unicamp in Brazil, and working on things that are related to teaching ultrasound, okay. And it's only to show you that the last 5 years we published like 12 articles. Then a kind of research that we do, and we should we think that is very important. It's like working on that specificity on sensitivities, and we showed like in a cohort of 53 patients, after a POCUS course that was an 8 hours course, continuous education, 8 hours, with 8 hours of hands-on, an immersive course. Our residents identified hydronephrosis with acute kidney injury with a sensitivity of 90% and specificity of 98 when compared with the formal image of the radiologist, okay? And the only false positive and negative cases were mild hydronephrosis that we didn't control when the patient was like catheterized in the bladder, if the image was after or before, okay? In conclusions and to end, I'm like in my 45 minutes, that was like the time that Civic told me. The internship started in 2009, and we trained more than 100 interns. Our team has like 3 people working on that. More than 1,400 patients were observed, and we changed the approach in 1 out of 5. We already had numerous presentations and publication. That's very important too. And this support and our administration in the hospital to continue and to expand the training. And we think that artificial intelligence in ultrasound will enable guidance through a complete POCUS examination and automatic diagnosis, fostering POCUS education, but it won't substitute humans at the bedside. I'll invite you to explore our POCUSX, every part that we have, like podcasts and our blogs and so on. And you can contact me and follow me. Thank you.
Okay, thank you very much for this wonderful talk, actually, and I hope our learners benefit from this. Jose, just a couple of things which I want to ask. You too are aiming what I am aiming here at SSMC, enterprise-wide change. So essentially, we're trying to change the language of physical examination from a traditional way of inspection, palpation, percussion to include insonation as part of your daily examination. This is a huge disruption to how things were done for hundreds of years. So what are the main drivers of change? What made you, obviously when you started off, I'm sure it was not easy. At what point you felt that the change was inevitable? And of course, you've done some amazing things. And what are the learnings which we could benefit from? Because we are trying to do that same here at SSMC.
Yeah, my journey was very particular, and I am like the kind of guy that is self-taught. It was in the beginning of this millennium in 2001, 2002, and I saw some surgeons like doing in the emergency room, like looking for the free fluid, but they were like 1 or 2, and they were very criticized. And then when I started my residence in internal medicine, we always had the problem like with acute kidney injury, and if the patient has obstruction or not. And then at that time, the CT scan, we had to count how many CT scans we already did in that week, okay? We couldn't do CT scans to every patient. We had control to the number of CT scans. And then the ultrasound machine was like in a room, but they closed the door, and the imagologist like 4 p.m. it was not in the hospital. And it was the first time I realized that I want to know to see if there is hydronephrosis or if the bladder is full of urine or not. Okay, because I saw once one of the hematologists doing that, and he told me like how to do it, and it was really like the physical exam. I was seeing like, man, this is really better than percussion, you know. And then it's only to put there and to understand some of the physical aspect, like I have to understand how to interpret an X-ray. You don't need an imagiologist to interpret a lung X-ray, okay? You work with that because you started in the faculty, and it's very practical. If not, imagine if you need an imagiologist to interpret every X-ray that you do in the emergency department. Probably it could be better because sometimes we don't find things that an experienced radiologist sees. But at the end, we are trained in internal medicine residents to see very well the X-ray. Okay. And that's what's my begin. Then I asked to my supervisor to go to learn to a radiology department, and they blocked me. You are crazy, man. You are not. Why you didn't go to radiology? And I tried to explain. Then I read a book that was from Ma, that is like one of the first books in emergency medicine and ultrasound, and I bought it, okay, from 2001. And I read the book, and then I started to teach in the university. And fortunately, we had a good group with two anesthesiologists, okay? And we were offered a big machine from the 90s, and we trained a lot, sonoanatomy, and we started to teaching anatomy and showing then the liver, where the spleen, and so on, and started my training. Then it was with the eFast. I started to do the emergency room. I learned with a surgeon, and then starting with a protocol as the eFast and knowing all the principles of ultrasound, I started to do the lung ultrasound, reading the papers of Liechtenstein, okay? And it was very crazy because people look at me very, very differently, that I was really the crazy doctor, you know? And then with knowing people from Brazil, it's very important networks. And now they are like my friends, Tiago Santos, and from the Unicamp, and they had like a more organized group there, and we started to give the immersive course. And then it was really, real revolution. It's like it was 10, 12 years ago. And when we started to teach, it's like learning four times, you know. And the immersive courses are very important. 1 day course, 2 day courses with live models, you know, and teaching how to do the ultrasound and to integrate, to starting to doing clinical cases. And then it was the revolution. Okay, we started with the immersive courses, we created a group, and now then in 2019 we started to the second step, that is to create a portfolio, and it's very important. And you can do only it if you dedicate your time, okay, in the hospital. And now that's the big challenge, because to reach this kind of analysis to everyone, probably you won't need only the hospitals. You will need also platforms like we created the POCUSX, like POCUSX, that is given support and given, because doctors do a lot of things, and they are like they have to go to the consultation, they have to make reports and so on. And then the artificial intelligence on top of that could help. Okay, I don't know if I answered your
No,
your
definitely.
question.
So, if I could
Then
add,
one important thing, I started like 12 years ago. I did like more than 10 ultrasounds per day. Okay, at the end of 2 months, I had like hundreds and hundreds of images. Okay, I started to record that then in a hard drive directly in the ultrasound machine, then started UCB appearing, okay? And it's really, 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 really important, okay? Because this is a technical thing, and you have to see patterns, and the patterns will only appear when you do it like more than 100 times, okay? It's,
So I think the key to distill that also lot of learnings there is it takes time to bring change. You need to collaborate with across disciplines. You mentioned your support from anesthesiology, and number three is build a network and and cross pollinate ideas, and that's key I think so to bring about change in healthcare. In the interest of time, can I ask you if my trainees or learners from Abu Dhabi want to come to your hospital to acquire training, what is the process? I mean, do you have to do any
yeah,
exam?
we have the experience now with we'll have a doctor from Angola. Angola speaks Portuguese, and we have some protocols with Angola. But I think there is the possibility to do observational training, because you have the problem if you are seeing patients, okay? But this is a problem that I think we can like work with the administration of the hospital very easily. And if having a tutor like me, or now I'm working with Dr. Sheila, and being a tutor, I think it's really and really possible, because we have the experience in other specialties, in intensive care, cardiology. Sometimes we see that doctors come to work like in fellowships. One of the main problems is like money, okay? Because always the hospital will ask who will pay, okay? And that's sometimes the problem. But I think working in cooperation and putting that clear, that is feasible. I'll tell you at the end of this year, because it will start in October. How did it go with our first international doctor from Angola? Okay.
Definitely, Jose. Thank you very much. And for those who had some technical issues in the beginning, I apologize. Jose, it was wonderful hearing your experience. And I appreciate the way you put the context that point of care ultrasound is not to replace what the radiologists do.
Yeah,
Just extending
very
our
important.
examination. We are just answering yes or no questions and providing timeliness of care. And that is our focus, is to help enhance the physical examination, not to encroach on what the radiologists do. It was a lovely meeting you, and I hope to continue our conversation. And I would love to see if we can meet offline to discuss some academic collaboration about how to build training programs and develop QA systems on point of care. Thank you very much, Jose.
Thank you a lot.
Thank you. Bye bye. Bye bye.
Bye bye.